Hey, Dr. Scott Gray here with Top Minds, where we talk with the top minds in healthcare, life, and business, such as the founder of the Orlando Magic, Pat Williams, and so many more, and how they're making a difference in the world today. And I'm really excited to bring to you today a wonderful doctor that can help with joint pain, chronic pain. Before we get to our doctor today, let's do a quick sponsorship message. And this episode is brought to you by Connect Relief. That's Connect with a K, connectrelief.com, where we help connect people with the best doctors in the country, like the one we have today, to get out of pain. So if you thought, is there anything I can possibly do to get out of pain when I feel like I've tried everything out there, contact us today. Go to connectrelief.com. That's Connect with a K, and to find a doctor in your area. So today, let's get to the good stuff. I'm super excited to have an amazing doctor with us here today who's helped so many people in pain, specifically as an orthopedic surgeon. We've got Dr. Christopher Gaunder here, currently serving at Wright Patterson Air Force Base in Dayton, Ohio. And so he graduated from medical school in 2012 with honors, and he's doing some amazing things with procedures to help his patients get out of joint pain, get out of chronic pain, both with his specialty in orthopedic surgery, as well as some things he's done with autologous stem cells and regenerative medicine. And so we're here to learn today from Dr. Gaunder, one of the top minds in this field. Welcome to the show, Dr. Gaunder.
Thanks for having me.
Yeah, thanks for being on here. I'm excited to just talk with you today about what you're doing and what you're up to. But before we get to the medical stuff, I'm just going to ask you this. What is something interesting about you that most people don't know?
Man, that's a loaded question right there. There's so many ways you can go around. I played college football. I was a huge Bulldog fan and played on that team from 04 to 08. So we had some really good years with No Sean Marinos and Matt Stafford. Oh, wow. A lot of awesome guys. Kind of a little known fact about the orthopedic surgeon. I said, I'm a big foodie, man. I love food. It's a huge passion of mine. I always joke around with my wife, who threatens to divorce me every time I bring it up, that my second career is going to be opening a restaurant. She goes, "You're absolutely crazy." But between sports and food, I could easily find a second career if this whole orthopedic surgery thing doesn't work out.
So sure. So what position did you play at Georgia?
I was a linebacker. Pretty much special teams, kind of utilitarian guy, stick me wherever they need me. But yeah, it was fun.
Very cool. Well, man, I didn't know that. That's awesome. So let me ask you this. What got you, so as an orthopedic surgeon, obviously trained traditionally, done, the residency, all the normal stuff. What got you started? I think one of the things that interested me about what you're doing is this getting into autologous stem cells and the regenerative medicine side of things. How did that even come about that you started incorporating that with your typical surgical procedures?
Yeah, that's honestly a really great question. And maybe my pathway is similar to some, maybe completely different than most. It just kind of depends, through your training, and we'll bring this up. I use these terminology all the time, but evidence-based medicine, right? Do we have evidence-based medicine for this? And that's really fancy medical lingo for, is it a validated study that's been peer-reviewed and randomized and appropriately blinded to meet current research criteria? And that's what we try as physicians and in our learning to predicate our practice off of. And it truly is the practice of medicine. This thing is, as we're going to discuss, why you have me here, is that it's always evolving. And what I was seeing, in our military population is that we have a fairly unique population, although I have seen it in other sectors as well, of a very young cohort of patients, 30s, 40s, that maybe to no end of their own. Maybe it's genetic, but a lot of the time it's post-traumatic or, some sort of other entity that led to their early arthritis. And these people were candidates for definitive surgical fixation in their early 40s, early 30s even, that, if I just showed you an x-ray of these guys, any orthopedic surgeon, 10 out of 10 orthopedic surgeons in the room would have said knee replacement. Raise your hand, answers knee replacement, answers hip replacement. With that said, even though we're leaps and bounds in the technology of arthroplasty than where we were 15 years ago, nobody, when you start sitting down and talk with a 30-year-old guy about his best option being a total knee, doesn't sound exciting. And so that's when we kind of started saying, all right, you know, what else is out there for these guys? What other options do we have? And even if it's not a definitive management, well, how can we extend the longevity and quality of life of these patients I'm seeing? And that's kind of where I would say, you know, the introduction was made to regenerative medicine in my practice.
Yeah. And how long have you been doing that? When did that start for you?
You know, we got exposed to it early, doing my training in San Antonio Center for the Intrepid, which is a phenomenal institution that really takes care of a lot of our wounded warriors. Recently highlighted in the Alex Smith 30 for 30. I don't know if we've got any sports fans out there where he did, you know, if you're a professional quarterback or you're a wounded warrior, you can get treatment here apparently. But needless to say, he got all his care, or he got a lot of his post-operative care there. And we just were seeing these guys with traumatic war injuries. You know, we did a lot of limb salvage, and then that predicates itself for early arthritis in these guys. And so in that regard, we were really kind of pressing the envelope and what we can do for these guys outside of, you know, big surgical interventions in terms of a joint replacement or something like that. And so that's where we kind of got initial exposure. And then, like I said, just being in the military practice kind of precludes it to these unique individuals that are in this particular circumstance.
Yeah. And so when you talk about these guys that are like in their 30s and 40s, when you look at that x-ray, if you looked at that x-ray and didn't know their age, how old would you think they were?
You know, you would think they were much older. And I will look at, I look at 80-year-old x-rays and I'm like, wow, that looks like a 30-year-old knee. I mean, not as commonly, but, you know, sometimes, you know, the x-ray doesn't do the patient's age justice. And so more, you would look at that x-ray and without a doubt, you know, your traditional training, absolutely, you'd be like, they need a knee replacement. Like, you know, obviously there's always non-operative management, and you can trial, you know, there's a bunch of different options always there that is not surgery. But just looking at their x-ray, and that's the worst thing to do as a surgeon, right? You know, it's a clinical picture, it's the patient's history, and then it's the x-ray. But sometimes an x-ray is, a picture's worth 1,000 words, right? And that's almost what that x-ray is. And so not that you put the cart before the horse, but you look at that x-ray and you're like, oh, that's a total knee.
Yeah. So, and I want to kind of talk about one of the big things out there. I think when people started talking about stem cells, they started acting like it was some kind of magic bullet or something like that. And the more I talk with, you know, guys like you about it that, you know, really know your stuff, you know exactly what's going on in there. You know, I don't see it as a, hey, you're going to get this thing and then you're going to be great for the rest of your life. What's the realistic expectations people should have when they, you know, let's say they've got a 60, 70-year-old knee? What's a real expectation someone can have getting stem cell therapy? And obviously there's a lot of medical history and things, but just as a generalization and not giving medical advice here.
Yeah. And that's a great question. Great question. Honestly, majority of preparations of stem cells, and there's a lot of variants that we could get into on how they're prepared, where they're harvested from, all that stuff. The majority of the preponderance of stem cells available in the market, you can fairly comfortably say that you're going to get a safe product that will be as safe or equal to in its efficacy than what we're using now. And the problem with it is that obviously, you know, in an insurance-driven healthcare system, your insurance are not going to pay for these as a whole in general. There's always exceptions to every rule. And so because of that equal to efficacy statement, you know, it's obviously difficult to, you know, tap the insurance market. And so I can confidently say that, something is equal to as advantageous as anything that is covered in the insurance market. The way they're being prepared now is much, much cleaner and safer than it was 10 years ago when stem cells first hit the market. Realistically, I can confidently say that with multiple, fairly well done studies that say that there is equal in their efficacy and safe. Now, obviously, we're not even discussing this if we don't think there is more of a benefit. And obviously, I think both you and I have seen some of that. But without a question, the literature is very clear that it's as equal and as safe as anything on the market.
So even with the, autologous that you do, like let's say you're talking with one of these guys that's got this knee that's looking really bad, and someone said total knee, and you come and say, look, we're going to do this. What do we say? What do you say to that person? Like, this may give you 3 to 5 years, like maybe for lucky 10 until you need one. What's a realistic look at something like that?
Yeah, and honestly, that's the $1 million question. We know that there is going to be some benefit. To the degree which the benefit's going to be obtained is a patient-specific outcome. And to say that I don't have patients that say it's the best thing that ever happened to them, for 6 months, a year, 2 years, I've had all those camps. And so if I could roll that magic dice and say, listen, if you go with this therapy, you're looking at 2 years of relief. You're looking at a year pain-free relief without, a knee surgery. Man, I know everyone would take that, but I think, and no one can really give us that, right? Even in the, the things that we have that we've been using for years and years and years. You talk about steroids, hyaluronic acid, the most studied, even when we get to like other biologics and PRP, no one can say, I can say on average, I hope that you're getting at least 6 months to a year from these, because if you're needing them more frequently than that, our conservative management's starting to lose its efficacy, and we need to think about other options, because what we're talking about is quality of life. I can inject your knee with anything, saline, and tell you not to use your knee. And, there's going to be some placebo effect to that, right? But what I want is a quality of life that you're happy with. I'm injecting your knee, and you're getting back to activities. You're getting back to a quality of life that's suitable for you. You don't want to tell anyone, 30 or 60-year-old, hey, yeah, I inject your knee, but don't do anything on it. Don't be active. Don't go hiking. Like, that's not the goal of this. And so, I think everyone's different because everyone's activity level is different. Everyone comes with a preconditioned, stratification. If I inject your knee and you haven't been hiking in 2 years, don't go jump on the Appalachian Trail tomorrow because I injected your knee and expect wonders to be made, right? The preconditioning aspect of your therapy just isn't there. But, within certain notions, if you're not getting 6 months to a year from your injection or therapy, I think that's associated with a decreased quality of life that you need to find another treatment, whether that's another non-operative management or, hey, I've used everything non-operative to my disposal and now I'm ready to think about something surgical. But 6 months to a year, I know that's a long-winded answer to your question, is what I would want you to receive from an injection, any injection.
Yeah. Okay. And so have you noticed any difference? Because I know you've used different things and all that you've done. So there's, you just mentioned hyaluronic acid, cortisone. I know there's like PRP where they draw the blood and, do the centrifuge. Do you notice any difference in those? Do you, like, let's say it was your knee, what would you want, if it's not an operative thing? I don't know if you want to go there or not. I don't know if there's anything you can or can't say there on that, but
no, again, a great question. And I'll tell you, my patients come to me with that all the time. And I will have to say it's each patient, it's a patient specific answer, right? you know, ideally steroids are great for what they do, but they were diagnostic tools. And that's what we initially used, you know, a steroid. So that's your traditional cortisone with a lidocaine mixture in it. Those were diagnostic tools that had a therapeutic benefit. And because of that, you know, we now have a multi-million-dollar, billion-dollar industry of something trying to recreate it. We know we can't constantly infuse your knee with steroids. It's not good for it. And that's why your doctor does limit the amount of exposure you have to it. And we have a lot of studies that say, you know, in appropriate dose quantities, it's safe. So just think that you got one steroid, your knee is, you know, no longer any good. It isn't appropriate either. With that said, as we get further and further out from, you know, chemical alterations, we're putting Band-Aids on arthritis. We're not reversing any changes, right? And that's where the biologics kind of come in. And, you know, PRP, for what it is a very potent anti-inflammatory that's derived from your blood. And there's not a more, you know, natural way to do that. But again, PRP is not stem cells. And so they can be marketed as such, which isn't necessarily truth, and just be careful of that. But it is a potent anti-inflammatory, and there's been multiple studies that show it's as effective and equally safe as any other of the injections we've discussed. And so that's a viable option, you know, if someone looking to do something, you know, but again, the cost of that's going to be something that needs to be thought of for an individual basis. And then stem cells kind of have their market in that same regard, that they're potent anti-inflammatory agents. And what they're doing in the knee is probably a whole podcast for another time. You know, we could get into the chemistry and actually of what's going on, depending when and where we're injecting the stem cells. But for simplicity of discussion, if you think of stem cells as, you know, PRP on steroids, they're going to do a really, really good job of decreasing the inflammation in that joint space that they're being introduced to. You know, for me in particular, I'm going to talk joints just because that's predominantly what I deal with. And so if I had my option, I think I would go stem cells. With that said, you know, I have to have real discussions that this is safe. It's an excellent treatment, but I can't guarantee that I'm going to give you leaps and bounds different results than what you've had before. And if you're having to mortgage your house to get these injections, then they're not right for you. And no treatment where you're putting your finances or your life in turmoil or stress for medical management, you know, it's a hard conversation to have with a patient. And so you have to meet each person where they're at on an individual basis and go from there. I hope I answered your question without.
Yeah, very well said. I mean, because it's all those things are just such big considerations. And, you know, like you said, if people are putting themselves into financial stress, I mean, that's a whole nother health issue that happens there too. And so you got to look at the whole picture. And so let me ask you this. Do you have any story or patient, obviously we're not going to talk names or anything, but any success story or something that you were just, you know, really excited or proud of, and maybe someone that just came in with a really bad knee and able to get them walking again? Just kind of share an experience maybe you've had.
Yeah, I mean, I think I'm sitting here and growing my interest in this field because of success stories. And, you know, I think anecdotal evidence, which is one person's viewpoint, is probably the worst evidence, and I'll be the first to admit that.
Yeah.
With that said, it's hard to not say, well, in my practice, I see this, because in my practice, this is what I see. And so I see a bunch of young guys in their 30s and 40s who have got knee arthritis. Like I said, that I'd throw up their x-ray in any orthopedic meeting, and, you know, I'd have 9 out of 10 colleagues say they need a knee replacement. And then I'd show that their age is 32, and they'd be like, oh man, that sucks for them. And those are the patients I initially started out with, you know, and majority of the patients had failed conservative management of one kind or another, whether it was one of the injections we talked about, steroid, PRP, hyaluronic acid. So I kind of took my worst, toughest patients at first and said, I want to try this on them because the other alternative, a total knee at 32, isn't a great answer. And, I had success. They did well, and they, where they were at my door every 6 or 8 weeks saying, is it time for another injection? Can I get another injection, Doc? 6 months, I haven't heard from them. And so, knowing that, again, anecdotally, you go to confirm that in the literature, and there's a lot of studies that demonstrate, similar results, although they're, for the most part, a single provider analysis, retrospective studies, we don't quite have the evidence-based, double-blinded control that we'd love to hang our hats on for stem cells. Man, they're definitely working, and they're, like I said earlier, I can confidently say they're not causing more harm to anyone, and they're definitely having a benefit. And so for the right patient, in those right scenarios, I think it's an awesome option, and I'm glad that I am able to offer it to my patients, when it's a tough scenario like that, and you're talking, complicated surgery versus the alternative. And as those patients have kind of demonstrated themselves to be successful, some of my toughest patients, then you run into the subset of other patients in their 50s who are still just as active, or they've lost 50 pounds and they've got a little knee arthritis, but they're trying to get a new lease on life, and they don't want a big surgery right now, or they're 2 years from retirement. And if I can just make it to retirement, Doc, and then I'll do whatever. And it's like, okay, but this isn't working anymore. I've started broadening the scope of the patients that I'll indicate that for. Again, using it on a patient-by-patient basis. But for the most part, I will say hips are, body part selection is important. But, for the most part, the type of arthritis is important when you're dealing with osteoarthritis versus an inflammatory arthropathy. That's predicated on the immune system. When you start getting into rheumatoids and all the different types of arthritis that are immunologically driven, you have to be careful about treatment options. But for pure osteo, it seems to do pretty well.
Yeah, awesome. So you've mentioned a couple things already about, don't go jump on the Appalachian Trail if you haven't done it, and if you haven't done your therapy and that kind of thing. What do you find most important for patients to know, after they have a treatment done? Like, what do you see for people getting the best results? And again, I know it's really patient to patient, but what are some kind of general rules of what people can and can't do after a treatment?
Yeah, no, that's a great question too. I say I want you to go back to your normal activity as soon as possible, because really in those first weeks are when you're going to see the most benefit in my hands. And so, but it's one of those things that if you came in and you were a marathon runner and you ran marathons in your 30s, and now you're in your 40s and you can't get out of bed because your knees are killing you, you don't get the injection and go back to try to run marathons just because you used to be able to do it. I get all excited, and my boys we'll be watching a football game. My kids will be like, Dad, you could still do it. And I feel in my heart that I still could, but I know I really couldn't. Just because I have pictures on the wall of what I used to be able to do doesn't mean I could go out and do it today. And so similarly with that, but the converse is you got to keep moving. And so if you weren't walking before, you got to do something. And there's always a graded stage of movement. And so my example of that is, you're running marathons, you can't do that anymore. You're not, even running hurts. Well, is there an elliptical? Is there a way to cross train where you can get the motion in without the impact? And then, well, the elliptical hurts. All right, aerobic therapy. Let's put you in the water, get that joint moving. And so it's finding the least grade of impact that will allow for movement of the joint as soon as possible. And so if you were in that really bad scenario where, just walking is extremely painful, if you're in, pursuing some sort of non-operative management, the immediate thing I want you to do is get moving. And that usually will mean putting you in some sort of aerobic or aquatic therapy to get the weight off the joint, but allow for the movement, and then slowly condition yourself back up, to walking, elliptical, and then, increasing activity accordingly. But just realize that every movement we have, shoulder, knee, hip, there's a grade to that where we can take gravity out of it. We can take the impact off of it and allow you to move that joint. I think one of the things I always joke around with my patients, grandma was right. If you don't use it, you lose it. And so unfortunately, I have the disservice of seeing patients who haven't done certain activities in 2 or 3 years because of the pain. And now we're left playing catch up, right? And that becomes much more difficult to get a patient back to that pre-activity level when they're 2 or 3 years out from ever doing that activity. And so getting them back moving as soon as possible in whatever graded fashion you can is going to eventually lead to that hopeful recovery that everybody's looking for when they come see us.
Yeah, I love it. And that's so true. And I mean, and seeing so many patients myself with degenerative joints and everything, I've always been, looking at what are some exercises we can do that are just less weight bearing, that, are doing less to your body when you exercise. And I actually found there's this water exercise equipment you can get now. And there's a guy that's famous for using it for, he's like a UFC, he's one of those MMA fighters. This guy named George St. Pierre that has all his exercise he does now is in the water. Yeah. So even these guys that are top athletes are doing it, and it's a great way to exercise. So I want to ask you kind of a question right before we kind of wrap things up here, but what are some action steps that people could take today? Just let's say they are suffering, what's something they can do today if they're just trying to get a little bit of relief? I like the idea of the motion, right? And non-weight bearing motion. What else? And maybe if it's just one thing or even two things, what could people do now to help to get a little bit of relief from whether it's chronic pain, joint pain issues? Yeah,
I think, obviously the motion's probably the biggest key. And usually a lot of the joints I see, they say, oh, it hurts every time I take a step. But then you realize you need about 0 to 120 degrees of motion for normal activities, getting in and out of a car, things like that. And if you've let your stiffness and arthritis kind of drive that train, so to speak, to the point where you're not moving that joint through that appropriate arc of motion that's going to give you what you need to walk up and down stairs, it's going to hurt. And so getting that motion back is going to be key. And that's what I really preach to my joints patients that are not quite candidates for something surgical, and we're trying to give them as many options to proceed in non-surgical management. Obviously compression is one of those things that goes underrated, I think, a counterforce to that joint. And so whether it's a sleeve or an ACE, especially with vigorous activity, and then wearing that after the activity is done to prevent swelling, because a lot of times it's a swelling of the surrounding joint. A little difficult with a hip, obviously, and so that's more your knee, ankle type arthritis patients. But compression is one of those things that really does go a long way. And right now it's hot everywhere. No one wants the idea of wearing a compressive wrap, while they're outside mowing the grass, because that's no fun, man. They're just sweating and dying out there. But, that compression does go a long way. And when it's safe, outside liver and kidney function, alternating just Tylenol and ibuprofen. I'll tell my patients who are in really a lot of pain, and they're waiting for whether it's an injection option or a surgical option, safely alternating those medications when taken appropriately, can be really safe and effective anti-inflammatories. Now, the goal is not to, be a pill popper and taking medications your whole life. That's why we're using these non-operative treatment modalities as well as surgical interventions to try to get patients in a different place where they're not needing those medications regularly. But from an acute standpoint, especially an inflammatory standpoint, those two medications are going to work better together than individualized. And what they'll always tell me is, oh, Tylenol does nothing for me, doc, or ibuprofen does nothing for me, doc. I agree. Try taking them together. And synergistic multimodal pain management modalities has been the way of the future, from going where, I had patients who had their knee replaced in 2003 and they said they laid in bed, for 3 or 4 days, and then they finally went to a rehab facility. That same patient will have surgery with me and they're home the next day. They're doing stairs the same day of surgery, if they even really needed to stay in a hospital. And that's not predicated on necessarily my surgery skills, as it is what we've developed around the surgery from a multimodal pain management modality and structure that is going to allow those patients to do more earlier. And so that's why I always say synergistic medical management is paramount. And so when you can safely find medications that can be used together, Tylenol and ibuprofen are a great example of that. They're going to synergistically work better than any one medication if you're just taking that sole agent by itself.
Got it. Awesome. Well, thank you for the advice, Doc. And I'm going to wrap up here. So where can people go to learn more about you if they want to see, how to contact you, Dr. Gaunder?
Yeah, I think the internet's a valuable tool, and where I'm at and what I'm going. I think my wife probably checks the internet when she hasn't heard from me all day to see what time I'm going to be home. So I think that's probably the easiest way at this point. Through the different healthcare provider websites, I think that's probably the most beneficial and easiest. Obviously, multimedia outlets and stuff, I use sparingly, just from a patient confidentiality standpoint. Patients don't even know that their information is that important, and really had to get off the social media network in that regard. Patients, thanks, doc, posting their pictures and stuff like that, which is really flattering and honoring, but at the same time, they don't realize they're violating their own, private healthcare information. It's like, oh man. So
right.
That's probably the easiest way, to kind of figure that out.
Yeah, very good. All good, man. And we'll put any links that we have down below in the show notes. And I know when I originally heard of you, I looked you up and I saw all but one of your health grades was it's 5-star across the board. So you probably did have a bunch of people posting their pictures on your website. So I could see why that could happen. But hey, thanks for taking the time, Dr. Gaunder, to speak with us and share your expertise on this. We really, really thank you.
Well, I appreciate what you guys are doing and just creating a forum to bring these things to light. It's been, in my short practice, it's gone from taboo to even talk about these things to really bringing them to the light and saying, hey, these are your options and these are realistic expectations to get, and just creating it more around the patient, letting them have a say in their healthcare instead of just coming in and dictating it. We really changed the face, the way medicine practices in that regard. And it's fun. It's fun, to know patients have input and buy into their care, and we're in this together. I want the best outcome for our patients, as I know you do yours, and, getting their input and where they want and where they see themselves, I think ultimately leads to that. And so forums like this have done nothing but help educate patients and their options and what's out there and what's the best way to go about that. And I love it. My patients will say, they come in with that list of questions like, I went to the website and I was looking stuff up on you, or you did research in this, or, I heard you here and you talked about this, talk to me about this. And, they feel like they're burdening me, but these are my favorite conversations to have. And so I love it when patients come educated on their options and want to talk about them, and they're not wasting anyone's time. They're adding to the love of what we do. So.
Absolutely. And we encourage people do as much research as possible, find out what's out there, and it's your health, right? So it's everyone should be looking into it and really figuring those things out. So, and if you want to, connect with Dr. Gaunder, if you go to the connectrelief.com, that's connect with a K, connectrelief.com, we can get you connected with Dr. Gaunder as well. So feel free to reach out to us there. Again, that'll be down below as well. So thanks, Dr. Gaunder, and we'll talk to you again soon.
Yeah, thanks so much, man. I really appreciate the invite.
My pleasure.
All right.